Hello and welcome. Today let's talk cardiovascular system, another very fascinating system. So this is going to be chapter 12. Now when we talk about the cardiovascular system, we'll see the cardiovascular system is going to be made up of three major organs. Number one, we have the heart. Number two, we have our blood. And number three, we have our blood vessels. We have our blood vessels. Let's go through and let's talk first our blood vessels, and then we'll look at our blood, and then we'll take care of the heart. And then we'll have a nice idea of this whole cardiovascular system. So here when we go through and we talk about the blood vessels, I would like you to know that the cardiovascular system has three major types of blood vessels. Number one, we have our arteries, which are responsible for carrying blood away from the heart. And this will also include the smallest branches, which are called the arterioles. Number two, we have our capillaries. Our capillaries then are going to receive blood from the arteries. And our capillaries, they're going to allow for exchange of materials with the tissue. Our capillaries will allow for exchange of materials with the tissue. And then number three, once the exchange has occurred, whatever needs to be sent back into the circulatory system then is going to be returned via our venules and our veins. Now the venules are going to be the smallest branches of the veins. They're all veins. They're all veins. Now they're going to be responsible for returning blood to the heart. They're responsible for returning blood from the capillaries to the heart. So the veins will be responsible for carrying blood from the capillaries to the heart, All of these vessels, they have a layer inside of them that's called an endothelium. All of these vessels, we'll see, are going to have an inner layer to them that's called the endothelium. This endothelium is going to be a layer of simple squamous epithelium that's attached to a connective tissue basement membrane that's going to have elastic fibers to it. All right, first then let's check out our arteries. Now when we talk about our arteries are going to have three layers to their walls. The wall is going to be made up of three layers in the arteries. Now, the innermost layer we determined is going to be the endothelium, which we said is made up of simple squamous epithelium. The middle layer is going to be the thickest layer, and it's going to consist of smooth muscle that can constrict to regulate blood flow and blood pressure. The outer layer, then we can see, is going to consist of connective tissue. We will have fibrous connective tissue and loose connective tissue making up the outer layer of our arteries' walls. Now, when we talk about our arteries, here you can see all three of those layers. First, we've got the outermost layer right inside of here. And then we've got the inner layer right inside of here, all smooth muscle. We had connective tissue out here. And then inside to this, internal to that, you can appreciate then the inner layer. The inner layer is made up of simple squamous epithelium that you see right inside of there in greater detail. Now, when you get to anatomy, you'll learn even further. There are actually three tunics. You have the tunica intima, the innermost layer, the tunica media, the middle layer, and the tunica externa, the outer layer. So you'll see that when you get there. And here we can appreciate all the layers in a photomicrograph of the arteries and the veins as well. So here they've marked it wrong. They're pointing to the inner layer as the inside of the vessel. So here we can see the inner layer is going to be this red layer you see right on top. This red kind of lining you have here, that's all the inner layer, the tunica intima. And then right underneath here, this is all muscle. This is all the middle layer, the tunica media, we said, the middle layer. And then right here on the outside, we have the tunica externa, the external layer. All on the outside. And then same thing here you can see with the veins, and we'll look at the veins when we talk about the veins. The internal layer, then the middle layer, and then the outer layer. And here in the veins, we'll see it's not, the middle layer in the veins is not going to be as thick as we can see here in our arteries. And we'll see why. So same thing we see here. Next on, let's talk, the largest artery in the human body is the aorta. The largest artery in the human body we'll see is the aorta. The aorta is approximately 25 millimeters wide. And we'll see the aorta, along with all other arteries, are going to carry oxygen-rich blood away from the heart to other parts of the body. Smaller arteries are going to branch off of the aorta, forming arteries, which are going to lead to then even smaller branches that are going to eventually be known as, we said, the arterioles. So arteries are going to branch off eventually into arterioles. Now, when we talk about arteries, I'd like you to think of blood vessels that are going to branch and diverge and fork. Branch, diverge, and fork. Basically, they divide. So you have one major artery, that's the aorta, and that's going to give off a whole bunch of different arteries, and eventually they're going to form arterioles, which are going to be even smaller arteries. Now, when we talk arterioles we'll see they're going to average about 0.5 millimeters in diameter. They're very small. And they can be dilated or constricted to regulate blood pressure. And we can take advantage of that when we want to regulate blood pressure in patients by giving them certain medications. All right, next then let's talk about our capillaries. Now, when we talk about our capillaries join our arterioles to our venules. They join the arterioles to the venules. They are composed of a single layer of endothelium with a basement membrane, connective tissue basement membrane. Capillary beds are going to be networks of many capillaries, and capillaries, we'll see, are going to allow for the exchange of substances across their thin walls to help maintain homeostasis. Substances such as oxygen, carbon dioxide, water, glucose, waste products, just to name a few things. Also scattered amongst capillary beds we'll see are going to be lymphatic vessels. Each capillary bed is going to have an arteriovenous shunt to it. This arteriovenous shunt is also called an anastomoses. These anastomoses, or these arteriovenous shunts, are going to allow blood to go directly from an arteriole to a venule, bypassing the capillary bed. And we'll look at that structure here, right in here. Here is the arteriovenous shunt. And we're also going to see, we're going to have precapillary sphincters. These precapillary sphincters are going to regulate blood flow into the capillary vessels. It's a really neat structure, and we'll look at that in a few seconds. So here, let's go through and let's talk about these capillaries a little bit further. They're extremely narrow with thin walls of only a single layer of endothelium. That's it, just a single layer. And that makes sense because we don't want to have a thick wall for these substances to have to make their way through to get to the other side. We want it to be a simple thin wall, thin layer, and they make their way through and they're off onto the other side. Our capillaries, we can see, are going to form vast networks in all regions of the body with a total surface area of around 6,000 meters squared. Next here we can see our capillaries are going to be organized into networks that are called capillary beds. So that's why we've been talking about capillary beds, and we're going to look at the structure of a capillary bed in a few seconds. So they're organized into networks called capillary beds that are present in nearly all regions of the body I mentioned. They're going to play an important role in homeostasis by allowing for the exchange of substances across their thin walls. So here we can see oxygen and nutrients can diffuse out of the capillaries and into the tissues and the cells. Waste and carbon dioxide can diffuse into the capillaries. Water may also leave the capillaries. And then excess fluid gets picked up by our lymphatic system because we said that's going to be found dispersed amongst these capillaries as well. So here we can see blood flow to our capillary beds varies. It varies so that only certain ones are going to be completely open at any given time. For example, after eating, capillary beds that serve the digestive system are mostly open. Those that serve the muscles are mostly closed at that time. Capillary beds have, we said, AV shunts that are called anastomoses, which are going to allow the blood to bypass the capillary bed. Blood flows directly from the arterial to the venule. So here you can check that out. So here we've got our artery. The artery then here leads to the arterial. And the arterial, you can see, leads to the AV shunt you see right here in the middle. And the AV shunt then takes this blood to the venule. And the venule then is going to direct it into the vein and back towards the heart. So here are the true capillaries you can see all along here. This is where the exchange then of materials will occur. And right inside of here as well, same thing down here. Here we can see at the openings to these capillaries, we have our pre-capillary sphincters. The pre-capillary sphincters are basically smooth muscle, and the smooth muscle, as we said, has the ability to snap shut, and when it snaps shut, blood is then going to be routed through the arterial and directly to the venule and out of this capillary bed. So pretty neat system. All right, next then let's check out our veins. Now when we talk about our veins, I want you to know our veins and our venules take blood from the capillary beds to the heart. First, we have our venules. Our venules are the small veins, and they're going to drain blood from our capillaries, and then multiple venules will join together to form a vein. The walls of our veins and our venules, we'll see, are going to have the same 3 layers as arteries, but there's less smooth muscle and connective tissue. Veins have valves, and these valves are going to allow blood to flow only in one direction, and that's going to be towards the heart, and prevent blood from flowing backwards. Valves are going to be found in the veins that carry blood against the force of gravity. Blood in the arteries is going to be kept moving by the pumping action of the heart. Now, when we talk about blood flow in the veins, here it's going to be different. Blood flow in the veins is mostly due to skeletal muscle contraction and our respiratory pumps, also the presence of our valves. This will all ensure blood is flowing in one direction, and that's towards the heart. Now, if these valves that I keep mentioning, these valves don't work properly, then the patient can suffer from what we call varicose veins, where you're going to have a pooling of blood then on the next valve that's found in the sequence, leading to that area becoming engorged with blood. These valves can become damaged due to disease or just simple aging. Veins, we'll see, are going to hold up to 70% of the body's blood supply, and they're said to act as blood reservoirs. Our veins act as blood reservoirs. So here we can see our venules drain blood from our capillaries and then join to form a vein. Our vein walls, we said, are structured similar to the walls of our arteries. There's 3 layers. However, there's less smooth muscle and connective tissue in veins compared to our arteries. Overall, the wall of a vein is thinner than that of an artery, and we saw that. So when we look at this picture, so here we can compare then the 2 structures, and you can see the differences when you look at the 2. So here we can see that unlike arteries and arterioles, blood flow in our veins is not kept moving by the pumping action of the heart. That pressure is going to be significantly low by the time it gets to the veins. Some veins, we said, have valves that are going to prevent backflow, especially the veins in our lower limbs, right? The veins that are going to be working against gravity. Blood flow in the veins is primarily dependent on our skeletal muscle contraction, because we'll see the placement of our veins is found between skeletal muscle. And then we have our major veins that are inside the abdominal and thoracic cavity that are going to be affected by our respiratory pressures that are going to be exerted every time we breathe in and out in these areas. And then we said we have our valves. Damage to the valves due to aging or disease may lead to then blood pooling in the veins. Here we can see varicose veins and hemorrhoids. They're going to be caused by veins enlarging as blood pools and becomes visible at the skin surface. And then due to their thinner walls, veins have a greater capacity to expand. So they serve as a blood reservoir. We said they can hold up to 70% of the blood from the body at any time. The largest veins we're going to have in the body are going to be called the venae cavae. We have a superior and we have an inferior venae cavae. They're going to be responsible for routing blood then into the right ventricle of the heart, we'll see. So both veins deliver oxygen-poor blood. They deliver oxygen-poor blood to the heart. Let's talk about then blood. Let's talk blood. So we've taken care of our blood vessels. So we can see now leading to and from the heart are going to be these sets of blood vessels. Now what's traveling inside of them? Blood. Now when we talk blood, blood is a liquid connective tissue. It's a liquid connective tissue. Besides nutrients and waste, blood is also going to transport hormones we saw in the last chapter. It's going to help regulate body temperature. Blood is going to help protect the body against invasions by pathogens. Blood also has clotting factors that are going to protect the body against blood loss. So blood is very fascinating. If blood is removed from a person and put into a tube and then centrifuged or spun at a very high rate, blood is going to be separated into 3 layers we'll see. So let's go through and we'll check that out. First then, talk functions. We saw many functions. Next then, blood gets placed in a test tube. It may be separated into 3 layers. The upper layer is going to be called the plasma. The plasma is the liquid portion of our blood. The other 2 layers we'll see, the other 2 layers together are forming what we call our formed elements. They form our formed elements. When we talk about our formed elements will include our white blood cells, or our leukocytes, and our platelets. They're going to be found in the middle layer. And then the bottom layer is going to be made up of red blood cells, or erythrocytes. We're also going to refer to them as well. First then, let's check out our plasma. Let's talk more about our plasma. Our plasma is going to contain inorganic and organic substances that are going to be dissolved, or we can say suspended, in water. Proteins. Proteins of the plasma make up about 7 to 8% of our plasma. Certain proteins are going to have certain functions. They will also help to maintain blood volume because they're going to be too large to leave our capillaries. So here we can see some of the functions of our plasma proteins. Some are going to be involved in transport, such as albumin, which transports bilirubin, and our lipoproteins, which transport cholesterol. We also have fibrinogen. It's involved with blood clotting. Immunoglobulins. They're there to fight disease. And some proteins are going to help maintain blood volume due to their large size we mentioned. So here we can see if we were to get our blood and centrifuge it, this is what we would have. You've got plasma right here on the top. Plasma makes up about 55% of our whole blood volume. And then next we have our leukocytes and our platelets. That's called the buffy coat. And it usually makes up less than 1% of our whole blood volume. And then underneath that we can appreciate our red blood cells, or our erythrocytes. And you can see they make up about 45% of our whole blood volume. So here we can see when we talk plasma, mostly water, proteins, salts, gases, nutrients, waste products, and other components that are going to be found inside of there. So next then, let's check out our red blood cells, or our erythrocytes then, in greater detail. Now when we talk about our red blood cells, or our erythrocytes, I'd like you to know that they're constantly manufactured in the red bone marrow of certain bones. Mature red blood cells, they don't have a nucleus. They do not have a nucleus. They lack a nucleus. And they are biconcave discs, meaning both sides are basically squished in. Both sides are flattened in. They look kind of like miniature donuts, is how I like to describe it. Now, these red blood cells, they carry oxygen because they contain hemoglobin. Because they contain hemoglobin. Hemoglobin is going to be a respiratory pigment. Hemoglobin contains 4 polypeptide chains, and each chain is going to be associated with a heme group and a complex iron-containing group. The iron acquires oxygen in the lungs and then it gives it up in the tissues. Red blood cells, we'll see, live only about 120 days. So let's look at some red blood cells. Here we've got a blood capillary, and we'll magnify the red blood cells. And here we can appreciate many erythrocytes, many red blood cells. And then here we can appreciate in the next picture a hemoglobin molecule. The hemoglobin molecule has got its globin chains, and then you can see the heme molecule, and then the iron attached to the heme group. Our red blood cells, we said, last only about 120 days, possibly due to a lack of a nucleus. They're destroyed in the liver and in the spleen. Iron is going to be mostly recycled. The heme portion gets degraded and added to our bile pigments. When there isn't a sufficient amount of red blood cells, or the red blood cells don't contain enough hemoglobin, the person suffers from anemia and feels tired and run down. There are 3 causes of anemia. Number 1, it could be due to low red blood cell production. Number 2, it could be due to a loss of red blood cells from the body. And then number 3, it could be due to a destruction of red blood cells in the body. Now, in iron deficiency anemia, red blood cell production is decreased. Commonly due to iron deficiency in the diet. Next, then, let's check out erythropoietin. Erythropoietin is a hormone that's secreted by the kidneys, and it increases red blood cell production and maturation in the presence of low oxygen in the blood. So when arterial blood carries a reduced amount of oxygen, could be because of anemia or high altitude. The kidneys, they increase their production of erythropoietin, and erythropoietin is going to speed up the maturation of our red blood cells in the bone marrow. So we talked about anemia. Next, let's talk about our white blood cells, our leukocytes. Now, our white blood cells, or our leukocytes, are bigger than red blood cells. They have a nucleus. They have nuclei to them, and they lack hemoglobin. So they don't have hemoglobin. Now, think about that, because hemoglobin helps to carry oxygen, and that's not the job of our white blood cells. That's the job of the red blood cells. That's what they have, hemoglobin inside of them. So the white blood cells, they don't have hemoglobin. Now, when we talk about our white blood cells, we'll see they are not found in numerous quantities as our red blood cells. Our leukocytes, they function to fight infection, and they play a role in the development of immunity, which is the ability to resist disease. Our white blood cells are going to be divided based on structure as either granular leukocytes or as agranular leukocytes. Your neutrophils, basophils, and eosinophils, they are your granular leukocytes, and they are going to be filled with enzymes and proteins which help the body defend against microbes. Here we can see neutrophils, they have multi-lobed nuclei. They are the most abundant white blood cell that we have, and they are able to phagocytize and digest bacteria. Basophils, then, they release histamine. They release histamine, which causes inflammation. Third, then we have our eosinophils. Eosinophils are going to fight parasitic worm infections. Third, we have our eosinophils. Our eosinophils are going to fight parasitic worms, and they are also involved in some allergies. Our agranular leukocytes then are going to include our monocytes and our lymphocytes. They have kidney-shaped or spherical nuclei. Monocytes are the largest of the white blood cells, and they differentiate into phagocytic dendritic cells and macrophages. Dendritic cells are going to be present in tissues that are in contact with the environment, such as our nose, our skin, our lungs, and our intestine. The lymphocytes are of two major types. We have B lymphocytes, which we can also refer to as B cells, and we have our T lymphocytes, which we also refer to as our T cells. B cells produce antibodies, while T cells are found as helper T cells and cytotoxic T cells that kill other cells. Our neutrophil counts increase in response to different bacterial infections. A person with infectious mononucleosis has increased number of B cells. In AIDS, the individual has a low number of T cells. Leukemia we'll see is a cancer that's characterized by uncontrolled production of abnormal white blood cells. So let's check that out. Here again we can see our blood after being centrifuged, being divided up into plasma, our buffy coat, and then our erythrocytes. Here we can see everything on a slide under a microscope. So here we've got our red blood cells. Okay, here there's two red blood cells stacked on top of each other. Same thing right in here, same thing here. Here's one red blood cell, another one right next to it, another one next to it. And then here we have our various WBCs, our white blood cells. So erythrocytes, or red blood cells. The plasma is serving as the backdrop. And then here we've got our platelets. So we talked blood has transport functions, regulatory functions, and we mentioned protective functions. Here we can see all of our formed elements. Red blood cells, white blood cells, and our platelets. Same thing there. Here we've got a nice image of a macrophage attacking bacteria. So here's all the bacteria, and then here's the macrophage actually mounting its attack against the bacteria. And we talked our white blood cells. We talked bacterial infections. Neutrophils are going to be elevated. Infectious mono, B cells elevated. We talk AIDS, our T cells are decreased. In leukemia, we have abnormal white blood cells. Let's move on then to our platelets, and let's check out blood clotting. Now we talk about our platelets. Our platelets are also known as thrombocytes. They're involved in blood clotting, and they come from megakaryocytes. These cells are platelets or thrombocytes. They form as a result of fragmentation of megakaryocytes in the red bone marrow. So these megakaryocytes basically blow up, and when they blow up, they give off a whole bunch of cells, little cells. And that's what you're seeing here. So here you can see you've got a whole bunch of platelets basically all in this area. So moving back then, when we talk our platelets, they're going to be produced at a rate of about 200 billion per day. We have anywhere from 150,000 to 300,000 per millimeter cubed of whole blood. They're going to be involved in the process of clotting or coagulation of blood. And last we can see here we have about 12 clotting factors that are going to participate with our platelets in helping to form a blood clot. Next, let's talk about capillary exchange. We're talking about exchange at the level of the capillary. There are two main forces that control movement of fluid through the capillaries wall. Number one, we have osmotic pressure. Osmotic pressure is created by salts and plasma proteins, as we can see. It's going to cause water to move from the tissue fluids to the blood. And then second, we have blood pressure. Blood pressure is going to cause water to move in the opposite direction from our blood to our tissue fluid. We can see here at the arterial side of the capillary, blood pressure is higher than osmotic pressure, so water exits a capillary at this end. And then midway through the capillary, these forces are equalized, so this results in no net movement of water. However, solutes now move down their gradients, nutrients and oxygen diffuse out of the capillary, waste and carbon dioxide diffuse into the capillary, and then last we can see the movement of gases is reversed in the pulmonary circuit. So let's look at that in the actual capillary here. You can see now water is able to make its way out at the beginning of the capillary. And then as we progress through, you've got all these other substances making their way through. And then here at the venous end, we can see pressures are going to change. Osmotic pressure is higher than blood pressure, allowing for net pressure of water into the blood vessel. So at the venous end, osmotic pressure is greater than blood pressure, so water moves into the capillary. Almost the same amount of water gets reabsorbed as what left the capillary at the arterial end. The small amount of fluid remaining behind can be absorbed by the lymphatic capillaries. That tissue fluid then will be called lymph. And then we can see it gets returned back to the systemic venous blood in the superior thorax area where our lymphatic system hooks up to our venous system. So here we can appreciate how all of those capillaries intermingle with one another. The lymphatic capillaries, and you got our blood capillaries there as well. All right, next one, let's check out the human heart. Now, when we talk about the human heart is going to be a cone-shaped muscular organ, and it's about the size of one's fist. It's found located between the lungs, right behind the sternum. It's tilted so that the apex of the heart, the pointed part of the heart, is orientated to the body's left. Let's check out then the heart in greater detail. We can see the heart wall is made up of three layers. You have first the middle layer, that's called the myocardium. External to that, you have the pericardium. And internal to the myocardium, you have the endocardium. So the middle layer is called the myocardium. The myocardium is the major portion of the heart, and it consists mainly of cardiac muscle. The layer external to the myocardium again then is the pericardium. The pericardium is the serous membrane that's going to be found surrounding the heart. Internal to the myocardium then we have our endocardium. The endocardium is found lining the inner surface of the heart. It's a membrane consisting of connective tissue and endothelium, which is simple squamous epithelium. Jumping back to the myocardium, I'd like you to know the muscle fibers or the cells of our myocardium, they're going to be branched and tightly joined to each other. So here we can appreciate a nice external view of the heart. Here we've got the heart, so here's the apex of the heart, and you can see it's pointed towards the body's left. Here we have our aorta, we said the largest artery in the body. And here are our vena cavae, superior and inferior vena cavae. And then here we can appreciate the blood vessels that service the heart's muscle and allow the heart to function like it needs to. So here we can appreciate all the arteries that are going to be responsible for supplying functional blood. And then here we have our veins that drain all of the blood away. So here you can see we have our right coronary artery and a left coronary artery, our two main branches. And then we have our left and right cardiac veins that are responsible for draining blood away. And then next here we can see everything together. So next then let's move to the internal anatomy. Now we talk internal anatomy. I'd like you to know that the heart is going to be separated into right and left sides by a septum. The septum is going to run right through the heart, separating it into right and left sides. The heart has 4 chambers. The upper 2 are going to be called the atria, and they are thin-walled, and they pump blood to our ventricles, the next chambers. Next, then we have our 2 ventricles. Our 2 ventricles are going to be thick-walled. They're thicker-walled compared to the atria, and they're responsible for pumping blood to our lungs and to the rest of the body. Here then we can see the heart is going to also have 4 valves. And these valves, they're going to direct the flow of blood and prevent its backflow or its backward movement. First, we have our 2 atrioventricular valves that I want you to know about. And they're going to be found in between the atria and the ventricles. These valves, we'll see, are going to be supported by strong fibrous strings that are called chordae tendineae. The right AV valve is also going to be called the tricuspid valve because it's made up of 3 flaps or 3 cusps. The left is going to be called the bicuspid or the mitral valve because it has 2 flaps. But even that now, with ongoing research, we're actually we're shying away from using the word bicuspid valve because they've discovered there's more than just 2 parts of the valve there. So AV valve on the left atrioventricular valve, or mitral valve, and it used to be called bicuspid. Next, then our last 2 valves. The other 2 valves are going to be found between the ventricles and their attached vessels. And these valves are going to be called the semilunar valves. Semilunar valves. So you have one pulmonary semilunar valve, and the other is called the aortic semilunar valve. The pulmonary semilunar valve is going to be found lying between the right ventricle and the pulmonary trunk. The aortic semilunar valve is going to be found between the left ventricle and the aorta. So let's check that out. Here you can see first is the right AV valve, also known as the tricuspid valve. And then here we have our left AV valve, or the mitral valve, again that used to be called the bicuspid valve. And then here we can appreciate one of our semilunar valves, found between the ventricle and the pulmonary trunk. And then the second semilunar valve is going to be beneath this valve, and it's found at the base of that aorta, and we can't appreciate that from this view. Next, then, let's check out and let's look at the blood flow through our heart. Let's look at the pathway of blood through the heart. So here we can see blood is going to flow from the vena cava into the right atrium, and then it's going to make its way past the tricuspid valve into the right ventricle, passing the pulmonary semilunar valve, making its way into the pulmonary trunk, and then into the pulmonary arteries to finally make its way into the lungs. And then from the lungs, this blood is going to be routed back to the heart. It's going to make its way from the lungs into the pulmonary veins, then the left atrium, crossing the bicuspid valve, making its way into the left ventricle, crossing the aortic semilunar valve, and then into the aorta to be distributed throughout the body. And then again back, right into the vena cava, right atrium, tricuspid valve, and everything over and over again. So here it is again. Here's the vena cava. So it makes its way into the right atrium. From the right atrium, it passes across this tricuspid valve to make its way into the right ventricle. From the right ventricle, blood is going to be passing this right semilunar valve to make its way into the pulmonary trunk. From the pulmonary trunk into the pulmonary arteries. And then from the pulmonary arteries into the lungs, we said. From the lungs, then it returns back via our pulmonary veins. You can see here, these veins here, they're actually opening right in here. Doesn't look like that from this view. However, you need to understand that. Just like these pulmonary veins we see emptying into the left atria, these right pulmonary veins also empty into this left atria. So then that blood is oxygen-rich blood now. It's going to pass across this left AV valve, making its way into the left ventricle, and then passing the left semilunar valve, the aortic valve, to be dumped off into the aorta, and then to be distributed throughout the body. So we've got all of that right to there. I would actually suggest you draw your own heart, and then you make your own arrows, and you understand it that way if you need to. So here we can see the same thing now. Oxygen poor blood is what's coming through the vena cava into the right atrium. And that oxygen poor blood is eventually, you can see, getting routed into the lungs, where it can become oxygen rich blood. That's why from the lungs then, we have now oxygen rich blood that gets routed back to the heart into the left side. So you can think of the right side of the heart filled with oxygen poor blood, and the left side is filled with oxygen rich blood. I personally like to think of the heart as two pumps side by side, and then each pump does its own task. Easier to kind of understand it then. So here we can see then, oxygen rich blood does not mix with oxygen poor blood. Blood must travel through the lungs to go from the right side of the heart to the left side. So think of the heart as a double pump. The right ventricle sends oxygen poor blood into the pulmonary circuit, and then the left ventricle is going to send oxygen rich blood to the rest of the body. That's why when you look at this left ventricle, it's much thicker compared to the right ventricle. So you can see the left ventricle is much thicker. It's got more muscle in its walls, and that's all there to help generate a stronger pumping force. Next, then, I'd like you to be familiar with the term cardiac output. Cardiac output is going to be the volume of blood that the left ventricle pumps per minute. So we can see for a person with an average of 70 beats per minute, the cardiac output is going to be about 5.25 liters of blood per minute. Next is the term pulse. I'd like you to know a pulse is going to be a wave effect that passes down the walls of our arteries when the aorta expands and recoils with each ventricular contraction. And we use the pulse to determine heart rate. So you can see the pulse can be used to determine heart rate. All right, next then let's talk about a heartbeat. Now when we talk about each heartbeat, I'd like you to know each heartbeat is called a cardiac cycle. Now when the heart beats, first the two atria will contract simultaneously. Second, the two ventricles will contract simultaneously. Then lastly, all of the chambers are going to relax. There's two terms I want you to be familiar with, and they include systole and diastole. First, we have the term systole. The term systole, it refers to the contraction of the heart muscle. The term diastole refers to the relaxation of the heart muscle. The heart contracts at a rate that can vary from 60 to 80 beats per minute. And we can see it averages about 70 beats per minute, we can say. Next, then here we can time each of those phases. So when we talk first atrial systole, that's when the atria are contracting and we have at the same time ventricular diastole taking place. This phase is about 0.15 seconds. And then when we have atrial diastole and ventricular systole, this phase we can see lasts for about 0.30 seconds. And then when we talk complete diastole, that will last for about 0.40 seconds. So you can see each cardiac cycle, each heartbeat, is an event that will last 0.85 seconds. Very fast, very fast. Next thing I'd like you to know, there was an instrument that's called a stethoscope that was used to hear the body's internal sounds. Using this instrument, the stethoscope, we can hear the lub-dub sounds of the heart. The lub sound is caused by the closure of the atrioventricular valves. It's caused by the closure of the atrioventricular valves. The dub sound we can see is going to be created by the closure of the semilunar valves. By the closure of the semilunar valves. So these sounds are created when the valves close. They're created when the valves close. And then when we talk about heart murmurs, it's a swishing sound, and that may be the result of a leaky valve. Let's look at then one full cardiac cycle here in this illustration. So here we can see we've got basically everything in rest, and then the atria are going to contract. The atria will undergo systole, and they move blood forward into the ventricles. Once blood moves forward into the ventricles, then here we can see the AV valves will close, and the atria will enter diastole, and the ventricles now are going to enter systole. With the blood moving forward, the AV valves closing, this creates that lub sound. Next then, we're going to see the semilunar valves are going to open up, and blood is going to be ejected out of the ventricles, so the ventricles are going to undergo systole. So when the ventricles undergo systole, blood moves forward, and blood's going to move into the large arteries, and then here we're going to see the ventricles are going to enter diastole. Once the blood has moved forward, the semilunar valves will close, creating the dub sound, and we'll start the cycle all over again. Next then, let's check out how all of this happens. So we're going to move to the intrinsic control of heartbeat. Now this rhythmic contraction of the atria and the ventricles is due to the intrinsic, or we can say the internal conduction system of the heart. This internal conduction system of the heart has muscular and nervous tissue characteristics. It's made up of, first we can see the SA node, the sinoatrial node. This sinoatrial node is going to be found located up in the dorsal wall of the right atrium. Second then, we have the AV node, the atrial ventricular node. This AV node is going to be found located in the base of the right atrial wall. So that right atrium is occupied by the SA node, which is found in the upper dorsal wall, and then this AV node, which is going to be found located in the base of the right atrial wall. So if we're to move right in here, we can see the SA node, and then down here we have the AV node. Next then we'll have the bundle of His, which is going to be found running in between the atria and the ventricles, which is then going to lead us to the right and the left branches of the atrial ventricular bundle, and they will lead us to the Purkinje fibers. They will lead us then to the Purkinje fibers. So let's run through the sequence here. We can see the SA node is going to initiate the heartbeat, and it's going to send out an excitation impulse. This is going to cause the atria to contract. When the impulse reaches the AV node, there's going to be a slight delay that's going to allow the atria to finish contracting before the ventricles are going to begin contracting. The signal for the ventricles to contract travels from the AV node through the atrial ventricular or AV bundle before spreading to the Purkinje fibers and allowing the ventricles to contract as a coordinated whole. The SA node is going to be called the pacemaker. So we can see here the SA node is called the pacemaker because it initiates the heartbeat. It sends out an excitatory impulse every 0.85 seconds. Excitatory impulses cause the atria to contract. And then we said excitatory impulses are going to travel from the AV node through the AV bundle, reaching then the Purkinje fibers. Now if the SA node fails, the AV node is going to generate a slower heartbeat. It's going to be anywhere from 40 to 60 beats per minute. And this then has to be corrected, and it's corrected then by an artificial pacemaker that patients then have to get installed. So again, we can see the SA node sends out impulses to the AV node, allowing then the atria to contract. The impulse then travels from the AV node through the branches of the atrial ventricular bundle, the right and left branches, making its way into the Purkinje fibers, allowing the ventricles to contract, then as a coordinated whole. Next, then, let's talk about extrinsic controls of heartbeat. We'll see the body also has extrinsic ways to regulate the heartbeat. First, we have a cardiac control center that's going to be located in the medulla oblongata, and it influences heartbeat via our autonomic nervous system. Right? We have our sympathetic and parasympathetic divisions we've talked about. The sympathetic division, it increases our heart rate, while our parasympathetic division is going to decrease our heart rate. And then next we have hormones, epinephrine and norepinephrine. They're released by our adrenal medulla, and they're going to stimulate the heart to pump faster, as we talked about in our endocrine chapter. All right, next then let's correlate one heartbeat to an EKG. An electrocardiogram or ECG or EKG or whatever you want to refer to it as is a recording of the electrical changes occurring in the myocardium. So here we've got some characteristic waves. We've got a P wave, a QRS complex, and a T wave. So when we go through and we talk about each of these waves, we'll see what they're all depicting for us. An electrocardiogram is going to be a recording of electrical changes in the myocardium that's detected at the skin's surface. And we're going to do that by placing electrodes. We're going to place electrodes on or near the chest, and they're going to be connected to an instrument that's going to detect and record myocardial electrical changes. So here we can see our P wave is going to occur when our SA node triggers an impulse. And it indicates that the atria are about to contract. So the P wave indicates the atria are about to contract. Next, in our QRS complex we see in here, the QRS complex, it indicates that the ventricles are about to contract. It indicates that the ventricles are about to contract. So if we use the terms diastole and systole, we can say here the P wave is indicating that the atria are about to undergo systole. So we're about to have atrial systole. The QRS complex indicates that the ventricles are about to contract. So the QRS complex indicates ventricular systole is about to occur. So last in here we can see our T wave. Our T wave is going to occur after ventricular contraction. So it's going to indicate that ventricular diastole is about to occur now. So let's correlate everything here with the intrinsic conduction system. So when the SA node fires, the atria will contract, and we're going to see that P wave indicates that event. And then the QRS wave is telling us that the ventricles are about to contract. And then our T wave tells us the ventricles have contracted. All right, let's move forward then. Let's talk about our vascular pathways. The cardiovascular system includes two circuits. It's made up of two circuits. First, we have our pulmonary circuit. Second, then we have our systemic circuit. Our pulmonary circuit, we'll see, is going to be responsible for circulating blood through our lungs, while our systemic circuit circulates blood through the rest of the body. So let's look at each of these circuits then in greater detail. When we talk again our pulmonary circuit, so here we can see oxygen-poor blood from all regions of the body is collected in the right atrium. Then it's going to be sent to the lungs from the right side of the heart. It returns from the lungs to the left side of the heart. So here we can see the pulmonary circuit. Blood from the body collects in the right atrium, we said. The right atrium, more specifically speaking now, is going to send it to the right ventricle, which sends it to the pulmonary trunk, which then routes the blood to the pulmonary arteries, which will route it to the pulmonary arterioles, then the capillaries, then the venules now, the pulmonary veins, to the left atrium. So here we can see that from the right atrium to the right ventricle, and then into the pulmonary trunk, the pulmonary arteries, the arterioles, the capillaries, the venules, and then the veins, and back into the heart, but now in the left atrium of the heart. So that's again making up our pulmonary circuit. Next then we have our systemic circuit. The systemic circuit we'll see is made up of blood that is oxygen rich, and it returns from the lungs, and it's going to get collected in the right atrium, we said. Oxygen rich blood then gets sent throughout the body except to the lungs. So here we can see the systemic circuit. Blood is going to leave the left ventricle, travels through the body, and it gets returned then to the heart. Here it goes to the aorta, into the arteries, then the arterioles, then the capillaries, venules, veins, and then back to the vena cava. So here we can see the illustration from that left ventricle into the aorta and then into the respective arteries and then the arterioles of the organs and then their capillaries and then their venules and then into their veins and then back into the vena cava and then the right atria. Next in here we can see the major blood vessels that I'd like you to know about. I want you to know the names of all of these major blood vessels. So from the aorta we can see then blood is going to be routed into the subclavian arteries to serve, then you can see the upper thoracic region, and then it'll be routed up into the neck and the head area thanks to the carotids, and then it's going to make its way down into the upper limb. So I want you to be able to go through and name all of these vessels and which area they are servicing, if they're providing oxygen-rich blood or if they're draining that area of oxygen-poor blood. So when we talk about the systemic circuit in greater detail, we can see we also have our coronary arteries. Our coronary arteries we saw before are going to serve the heart muscle itself, since blood from the chambers does not nourish the heart. They're going to be the first branches off of the aorta, and they're going to lie on the exterior surface of the heart. The coronary capillary beds join to form venules. The venules converge to form cardiac veins, which empty then into the right atrium. Next, then we have a portal system. When we talk about a portal system in blood circulation is going to begin and end in capillaries. For example, we have our hepatic portal system. It's going to be associated with the liver. We'll see capillaries from the villi of our small intestine. They pass into venules that are going to join to form the hepatic portal vein. This hepatic portal vein then carries blood to a set of capillaries in the liver, and the liver then will process this blood and then send it into circulation. So that hepatic portal system you saw began and it ended with capillaries. Next, then let's talk blood pressure. When we talk blood pressure, I'd like you to know first we have the term systolic pressure. Systolic pressure is going to result from blood being forced into the arteries during ventricular systole. Then we have the term diastolic pressure. Diastolic pressure we'll see is the pressure in the arteries during ventricular diastole. As blood flows from the aorta into the arteries and the arterioles, blood pressure, we said, is going to start to fall. The difference between systolic and diastolic pressure gradually diminishes. In the capillaries, we said, blood flow is slow and fairly even. So here we can see the velocity and blood pressure are going to be related to vascular cross-sectional area. Here you can see our arteries, they have greater pressure, and their pressure is also pulsatile. It goes up and comes down, it goes up and comes down, it goes up and comes down, goes up and comes down. It doesn't come down to zero, so that's not zero. Zero pressure is going to be down here, which is going to be pressure we're going to see inside the veins. Here you can see, so as the blood vessels are going to get smaller, we can see velocity and pressure starts to go down as well. So now in the capillaries, we can see the velocity of blood is very slow. We don't want high velocity because then we're not going to be able to have exchange. Pressure there is low as well. We don't want high pressure because the high pressure is going to move things out that we may not want to go out. And eventually then moving into the veins from the venules, you can see pressure making its way down. And then here you can see velocity starts to pick back up. So moving back here, we can see as blood flows from the aorta into the arteries and into the arterioles, blood pressure falls. The difference between systolic and diastolic pressure gradually diminishes. In the capillaries, blood flow is slow and fairly even, we said. I want you to know blood pressure is measured with a sphygmomanometer. This is a pressure cuff that determines the amount of pressure that's being exerted on an arterial wall. We usually use the brachial artery which is an artery in the upper arm, to measure blood pressure. A blood pressure reading consists of two numbers that represent the systolic and diastolic pressures. As we can see here, they're giving us these two numbers, 120/80. The 120 represents the systolic pressure, while 80 represents the diastolic pressure. And we'll see blood pressure is going to be expressed in millimeters of mercury, mmHg. Blood pressure in the veins. Blood pressure in the veins is low and therefore requires various methods to help move blood back to the heart. With blood pressure here being low, now what I said before should make more sense. I told you our veins are going to be placed in between our skeletal muscle. And when the skeletal muscles contract, this is going to help move blood forward. And then with the help of the valves, that'll help to ensure blood is moving in just one direction. And then we also talked about our respiratory pump, which is going to be basically our lungs. Every time we inspire, this creates a pressure difference inside the cavity and also in the abdominal cavity because of pressure being exerted from the diaphragm. And then when we expire, when we inhale and exhale, basically, this creates the pressure differences that again help to move this blood forward. Next, then, let's check out some cardiovascular disorders. Cardiovascular disease is going to be the leading cause of death in Western countries. Modern research efforts have resulted in improvements in diagnosis, treatment, and prevention. So you can see we've made a little bit of a progress, but there's still a lot more to go. First, we have atherosclerosis. Now here we have plaque buildup. Plaque accumulation of soft masses of fatty material, such as cholesterol, and they're going to be found beneath the inner lining of the arteries. So when this plaque starts to accumulate beneath the inner lining of the arteries, this plaque is going to interfere with blood flow by protruding into the artery's lumen, by protruding into the center of the artery. Plaques can cause clots to form by allowing platelets to accumulate. Now, if a clot breaks loose, then it becomes known as an embolus. If the clot remains stationary, then it's called a thrombus. So here let's check out some atherosclerotic plaque. So here we can appreciate the cholesterol crystals that make up the atherosclerotic plaque. And you can see how the plaque protrudes into the lumen, and that's going to interfere with blood flow. Now, if that happens in a vessel that's small like the coronary vessels, this can be detrimental to the patient. Next, then, let's check out a stroke. Stroke is going to be known as a cerebral vascular accident. An arteriole in the brain bursts, or it can be blocked by an embolus. Then what happens is we're going to have a lack of oxygen to the brain that can cause paralysis or even death because the brain tissue dies. Warning signs include numbness in hands or the face, difficulty speaking, and also temporary blindness in an eye. Strokes are going to be more common with age. Next, then, we have the term angina pectoris. Angina pectoris occurs when the coronary artery is partially blocked. This causes a squeezing or a burning sensation in the chest, which we refer to as angina pectoris. Next one is a heart attack, myocardial infarction. Now here what happens is a vessel becomes completely blocked. So what this does, then it causes a portion of the heart muscle to be deprived of oxygen. And when it's deprived of oxygen, it's not going to be able to function like it should. And that could then lead to lots of other problems. Even death can ensue. Next, let's talk about an aneurysm. An aneurysm is going to be a ballooning of a blood vessel. And this occurs most often in the abdominal aorta or the arteries leading to the brain. Atherosclerosis and hypertension can weaken the walls of the vessels, leading to an aneurysm. Now, if we have a bursting of the blood vessel, this can be fatal, especially if it occurs in our large arteries. That's going to lead to a large loss of blood. Through some very expensive procedures, we've got synthetic grafts that can be used to help replace damaged parts of vessels. Next, then, I want to talk to you about coronary bypass operations. Surgery bypasses blocked areas of coronary arteries. What happens is another blood vessel is grafted to the aorta and then to the blocked coronary artery past that point of the blockage. The proportion of heart attack patients receiving bypass surgery has decreased over the past decade. And last here we can see stem cell therapy may be a future treatment for damaged heart tissue. I mean, I can't wait to see what that can lead to. And then next here we can see clearing clogged arteries. We have a procedure called an angioplasty where a catheter is placed in the clogged artery and then a balloon that's attached to the catheter gets inflated. The expansion increases the lumen of the vessel. And then we can see stents are often placed also to help keep blood vessels open. So here let's check that out. Here we can see a catheter passing through the area that's actually blocked. And then here, once it passes through, the stent is placed. And then you can see the balloon is inflated, helping to increase the lumen space. All right.